If you are tuning in right now, there is a very good chance you are prepping for a clinical rotation in a psychiatric unit.
Right.
Or, maybe you are trying to understand the sudden disorienting diagnosis of a loved one. Or perhaps you are just feeding that boundless curiosity you have about the sheer, unfathomable complexity of the human brain.
Yeah, whatever brought you here, welcome.
Today, we are taking a deep dive into a topic that has honestly confounded scientists, philosophers, and families for centuries.
Absolutely. We are talking about schizophrenia spectrum disorders.
But we aren't just looking at this from a cold, purely clinical distance, right? Like, we aren't just reading off a list of diagnostic criteria from a textbook.
No, not at all. Our mission today is to really unpack the profound complexity of these disorders through the empathetic, incredibly nuanced, and intensely evidence-based lens of psychiatric nursing experts.
Because that perspective is so unique.
It really is. We are looking at the human beings at the center of the diagnosis. We're looking at the vital therapeutic relationships that actually foster recovery, the intense pharmacological tightrope they are forced to walk, and the holistic full-body care required to truly help someone heal.
It is such a vital perspective, and frankly, it's really the only perspective that does justice to the reality of the illness.
I completely agree. For so long, the symptoms of schizophrenia were entirely misunderstood. I mean, if you look back through the historical record, these behaviors were attributed to demonic possession,
Right.
or they were considered a divine punishment. They were completely disconnected from the reality of human biology and neurochemistry.
Which is wild to think about now.
Right. And even today, that historical shadow leaves a lingering, enduring stigma that patients have to fight against just as hard as they fight the illness itself.
Exactly. But as we dive into this source material today, we really need to firmly establish the modern baseline.
Which is that schizophrenia is a severe, chronic, but ultimately treatable brain disorder.
Treatable. That's a huge word there.
It's the most important word. And central to understanding what people with these spectrum disorders go through is understanding a state called psychosis.
Right, psychosis. That's really the key diagnostic factor here.
That is.
It's the dividing line between a typical neurological state and a schizophrenia spectrum disorder. For those who study this, we know psychosis generally means a break from our shared reality.
Right, experiencing hallucinations, delusions, or highly disorganized thoughts.
But to really grasp how we got to our current medical understanding, we have to look at the history of how this was categorized. Because it wasn't always viewed as a spectrum, was it?
No, it wasn't. Back in the late 1800s, the physician Emil Kraepelin described this condition as dementia praecox.
Dementia praecox.
Yes.
The-
He used that term primarily because it seemed to hit people early in life. That's the precox part. And it caused notable, seemingly irreversible cognitive decline, which he likened to dementia.
Which was a rather bleak outlook, honestly.
Very bleak. He was viewing it purely as an inevitable deterioration.
But then, in the early 1900s, Eugen Bleuler came along and really shifted the paradigm.
He did. He coined the term we use today, schizophrenia, which translates directly from Greek as split minds.
And we really need to pause here and clarify something for you listening, because pop culture gets this so wrong.
So wrong. It is crucial to clarify that he did not mean a split personality.
Right.
That is a massive misconception. He meant a splitting of the cognitive functions, a disconnect between thought, emotion, and behavior.
Makes so much more sense.
And Bleuler was also the first to realize there wasn't just one monolithic type of this illness. There was a whole group of schizophrenias.
A spectrum, essentially.
Exactly. And later on, Kurt Schneider categorized the specific clinical behaviors into first-rank symptoms, which are the bizarre delusions and hallucinations, and second-rank symptoms covering the rest of the affective and behavioral changes.
Okay, let's unpack this, because I really want to know how this illness actually unfolds in a real person's life.
Yeah.
Because despite the dramatic portrayals we see in movies, a full psychotic break doesn't just happen overnight on a random Tuesday, does it?
No, it rarely ever happens overnight. And mapping the timeline of this illness is just crucial, especially for psychiatric nurses or family members who need to know exactly where a patient is on this journey to provide the right care.
So what does that map look like?
The natural progression is typically described as a chronic illness that initially deteriorates over time and eventually plateaus. But the very first stage, occurring long before a full, recognizable psychotic break, is called the prodromal period.
The prodromal period. It's almost like watching gathering storm clouds on the horizon.
That's a great way to put it.
Like you aren't quite sure if it's going to rain or just blow over. This phase can actually begin in early childhood or early adolescence, right?
Yes, it can. And we are talking about things that, to the untrained eye, might just look like typical, albeit intense teenage angst.
Right, like tension, nervousness, maybe a sudden social withdrawal from friends.
Exactly. Picture a kid who used to be the captain of the soccer team. Suddenly, he just stops enjoying the sport, stops talking to his teammates, and spends all his time isolated in his room.
And they might have severe trouble sleeping too, or suddenly feel like people in the hallway are laughing at them.
Yes, that subtle paranoia starts creeping in. Sometimes there is a sudden, intense, almost obsessive preoccupation with religion or philosophy. Or they just feel fundamentally bad for no clear, articulate reason.
What's fascinating here is why identifying this prodromal phase matters so much in modern psychiatry.
It matters immensely because these are undeniably subtle, non-specific signs. I mean, you could take that list of symptoms and apply it to almost any teenager going through a tough breakup or adjusting to a new school.
Right, so easy to miss.
But if a clinician or a highly observant family member can catch these signs early and identify the subtle cognitive slipping before it solidifies into a major acute psychotic disorder, the entire trajectory of the person's life can be altered.
Because you're protecting the brain from the trauma of the psychosis itself.
Exactly. That is the key. Every time the brain undergoes a full psychotic episode, there is an inflammatory and neurochemical toll. It's neurotoxic to a degree.
Wow.
Treatment initiated earlier during the prodromal phase, whether that is low-dose medication, intense cognitive behavioral therapy, or even just environmental stress reduction, yields significantly better long-term outcomes.
The cognitive decline can actually be blunted.
Yes. But if it goes unrecognized, as it tragically often does because we just brush it off as a phase, the storm eventually breaks. The neurochemical tipping point is reached, which brings us directly into the acute illness phase.
And this acute phase usually hits in late adolescence or early adulthood, right? Like late teens to early 20s for men.
Yes, and often slightly later in the late 20s or early 30s for women.
This is when those subtle, easily dismissed signs turn into something disruptive and genuinely bizarre. It becomes impossible for the family or the school to overlook.
It really does.
The clinical accounts from the sources provide some incredibly vivid, albeit heartbreaking, examples of what this looks like for families.
They do.
Like in one case, a father described his son walking around their apartment for days, holding his arms up exactly like he was holding a heavy assault rifle.
Oh, wow.
He was pointing it at his parents and his younger siblings and just deadpanning, rat-a-tat-tat, you're dead.
That level of disorganized, threatening behavior is terrifying. Not just for the family, but profoundly so for the patient. They are entirely trapped in that reality.
Right. And another family watched their son start taking frequent, unexplained trips to local cemeteries.
I remember reading that case.
When they finally asked him what he was doing, he calmly explained he was going there to make mind contact with the deceased.
Which to him makes perfect logical sense.
Exactly. And shortly after, he started seeing his dead grandmother walking around their living room. He then became absolutely unshakably convinced that pipe bombs were hidden in ordinary objects around their home.
Like inside the toaster.
Inside the toaster, under the sofa cushions. When you try to put yourself in that young man's shoes, the sheer unrelenting terror he must be feeling.
It's unimaginable. He is living in an active war zone that only he can see.
It is a state of absolute psychological emergency.
Yes. During this acute phase, the behaviors become so confusing, so erratic, and so frightening to the outside world. And from a psychiatric nursing perspective, this is a critical period of immense vulnerability.
Because their ability to care for themselves just vanishes.
Exactly. As these psychotic symptoms worsen, the patient's executive functioning drops off a cliff. Their ability to care for their most basic, fundamental human needs, eating, sleeping, bathing, putting on weather-appropriate clothing, rapidly deteriorates.
They might stop eating because they believe the food is poisoned.
Right. Or they might stop sleeping entirely because they believe they will be attacked the moment they close their eyes.
And substance use often spikes heavily during this time, right?
Right.
As a misguided coping mechanism.
Heavily. They're desperately trying to self-medicate the terror. They often turn to cannabis, alcohol, or street drugs to quiet the voices or numb the paranoia.
Which, ironically, only pours gasoline on the neurochemical fire.
Exactly. It exacerbates the psychosis significantly. During this acute phase, the absolute highest nursing priority is physical safety.
Because of the suicide risk.
Yes. The suicide risk during this specific window is staggeringly high. The patient might be reacting to terrifying command hallucinations, or they might just be so overwhelmed by the sheer exhaustion of the paranoia that they see no other way out.
So what happens then? They have to be hospitalized.
Usually, yes. Patients are typically hospitalized during this time, often involuntarily for their own safety. The initial immediate treatment is laser focused on alleviating those severe acute symptoms with antipsychotic medications, forcefully normalizing their sleep-wake cycles, and simply keeping them alive and physically safe.
Then, once that immediate, life-threatening crisis is managed on the inpatient unit, you move into the stabilization phase.
Right.
The medications start working, the hallucinations quiet down, the paranoia loses its sharpest edges. But this phase presents a massive, distinct psychological challenge of its own, doesn't it?
It really does, because the patient and their family are suddenly standing in the wreckage of the acute break. They have to adjust to the reality that this wasn't just a bad reaction to a drug or a one-time nervous breakdown.
They're facing a chronic, severe mental illness.
Yes. And while the ultimate clinical goal is always recovery, relapse is a constant looming shadow. It isn't inevitable, but we know it is extremely common.
And preventing that relapse is really the core focus of outpatient psychiatric care.
It has to be. Because, as we touched on earlier, with every single relapse, the brain takes another neurochemical hit. It requires a progressively longer and longer period of time to recover the previous baseline of functioning.
You lose a little bit of cognitive ground every single time.
Exactly. And the number one undisputed trigger for relapse is medication non-adherence.
When a patient decides to stop taking their antipsychotics.
Yes. But it's rarely as simple as them just being stubborn. Impairment in cognition, coupled with the heavy side effects of the drugs, leaves these patients incredibly vulnerable to environmental stressors. A lack of social support, inadequate income, unstable housing, the profound stigma of their community. Any of these psychosocial factors can act as the catalyst for a neurochemical relapse.
Let's look at a clinical case from the sources that really illustrates this fragility. Take a patient named Arnold.
Arnold's case is a classic example.
Arnold is a 53-year-old farmer. He had been living quietly on his family's rural farm with his elderly mother for 30 years. He had his routines, he had his familiar environment, and he was relatively stable.
Right.
But then he experienced a profound, cascading environmental stressor. His mother passed away, and subsequently, because of financial issues, he was being forced to leave the family farm, which was literally the only environment he knew.
The stress of that is immense.
That massive emotional trauma and the total uprooting of his environment triggered a severe, acute relapse. He was admitted to the psychiatric intensive care unit under a court order after he became highly agitated and physically threatening with the authorities while being removed from the farm.
And by the time he was on the unit, his reality testing was completely gone.
Exactly. He completely refused to acknowledge his parents were dead. Even though he had personally attended both of their funerals, he firmly believed they were just away for a while.
Arnold's case is a textbook example of how deeply intertwined the biological illness is with the patient's external environment and their internal emotional world.
The stress of the grief and the eviction literally broke his brain's ability to maintain reality.
Yes. The delusion that his parents were simply away was his brain's ultimate desperate defense mechanism against a reality that was too painful to process.
Wow.
To understand exactly what Arnold and millions of others like him are actually experiencing on a granular level, we need to decode the symptoms themselves.
Because it's not just one thing.
No, in clinical terms, schizophrenia is characterized by a specific, complex constellation of symptoms. And the primary fundamental division we make is between positive symptoms and negative symptoms.
Okay, let's break that down, because for anyone newly studying this or dealing with the new family diagnosis, the terminology is incredibly counterintuitive.
It really is.
When you hear positive symptoms, you naturally think it means something good, like a sign of progress.
Right, but in this specific clinical context, positive means an excess or a distortion of normal brain functions. It's something that has been added to the person's experience that shouldn't be there.
And the two main positive symptoms we look at are hallucinations and delusions. There's a really helpful rule of thumb from the text to keep these straight.
Let's hear it.
Hallucinations involve one or more of your 5 physical senses. Delusions involve only your cognitive thoughts and beliefs.
That is a perfect way to remember it.
So let's start with the sensory additions. Hallucinations. These are sensory experiences that happen in the brain without any actual external stimulus. The brain is firing as if a sound or sight is real.
They can be visual, tactile, like bugs crawling under the skin, or olfactory, like smelling burning rubber.
But auditory hallucinations, hearing voices, are by far the most common manifestation.
Yes, auditory hallucinations are the hallmark positive symptom. But as clinicians, we don't just ask, are you hearing voices? We have to dig deeper.
Why is that?
Because we need to identify a specific, highly dangerous subtype, the command hallucination.
The command hallucination.
This is when the voices aren't just narrating the person's day or making derogatory comments, though those are incredibly distressing, but the voices are actively instructing the patient to act in a specific way.
Like giving them orders.
Exactly. Sometimes it's seemingly innocuous, like a firm voice telling them to stand up or eat their dinner or walk to the corner. But very often in the acute phase, it is incredibly serious.
The voices might command the person to self-mutilate.
Or to jump in front of a moving train, or to attack a family member or a nurse. When a psychiatric nurse is assessing a patient experiencing active psychosis, determining if they're experiencing command hallucinations and exactly what those voices are telling them to do is the single most critical safety priority during triage.
Because the patient might feel compelled to obey, especially if the voice sounds like God or a demon or a trusted authority figure.
Exactly. It's terrifying.
Then on the other side of the positive symptoms, you have delusions, which are strictly thought-based.
Right.
These are defined as fixed, erroneous, false beliefs that absolutely cannot be changed by logic, evidence, or reasonable argument.
And this is where a lot of families get really frustrated, because you cannot just present a patient with a photograph or a logical proof and expect the delusion to vanish. Their brain's reality testing apparatus is broken.
We see several specific types of delusions repeatedly in the clinical setting, don't we?
We do.
There are grandiose delusions, the absolute conviction that you possess exceptional powers, immense wealth, or global political influence.
Right.
There are nihilistic delusions, the deeply disturbing belief that you are already physically dead, that you are missing internal organs, or that a massive world-ending calamity is currently happening.
Those are especially hard to witness.
Then there are persecutory delusions, which is the classic intense paranoia, the unshakable belief that you are being watched by the government, plotted against by your neighbors, or actively poisoned by your family.
Yes, very common.
And somatic delusions, false beliefs about the physical body, like believing your brain is melting or your veins are filled with sand.
The bizarreness of these delusions is really what separates schizophrenia from other psychiatric states that might feature just mild paranoia.
It's a completely different level.
It is. And while these positive symptoms, the terrifying voices, the expansive delusions, are the most dramatic, and they are almost always what triggers a 911 call and brings a person into the hospital, they aren't necessarily the most debilitating part of the illness long term.
They aren't.
No, that tragic distinction actually belongs to the negative symptoms.
Here's where it gets really interesting and often incredibly misunderstood by the general public.
Completely misunderstood.
Because you would naturally assume that the screaming voices and the intense, paralyzing paranoia would be the absolute worst part of the disease. But it's actually these quieter symptoms, the negative symptoms, that absolutely devastate a person's ability to maintain a job, sustain a relationship, or just live a normal daily life.
Exactly. If positive symptoms are what is added to the reality, negative symptoms reflect a lessening or a total profound loss of normal human functions. It is what has been taken away.
We use a lot of A words in the clinical literature to describe these deficits, right?
The A words.
First, there is avolition, which is a profound, paralyzing lack of motivation. And we really have to be clear here for anyone listening. This is not laziness.
No, it is absolutely not laziness.
Mm-hmm.
The neural pathways in the prefrontal cortex that initiate goal-directed behavior are simply not firing. The patient might lack the biological drive to even comb their hair, get out of bed, or put on clean clothes, even if they desperately want to.
That distinction between avolition and laziness is so crucial for families to understand, just to prevent resentment from building up.
It saves relationships when families finally understand that.
And alongside avolition is anhedonia, which is the complete, crushing inability to experience pleasure in activities they previously loved.
Right. If they loved playing the piano now brings absolute zero emotional resonance.
Then we have alogia. That refers to a severe reduction in the fluency and productivity of speech.
If you ask them a question, you don't get a conversational answer. You get brief, empty, one-word replies because the thought process itself is impoverished.
Then there is affective blunting, which is a totally flat emotional response.
Their facial expressions might remain totally blank. Their voice monotone, even when they are discussing something intensely horrific, like a loved one dying, or something joyful. The affect just doesn't match the content.
And finally, ambivalence, which isn't just being indecisive about what to eat for dinner.
Not at all. It is experiencing equally strong, entirely opposing feelings about a person or situation concurrently, which makes it neurologically impossible to make even the simplest life decision.
When you look at those A words together, avolition, anhedonia, alogia, affective blunting, ambivalence, you see a recipe for total societal withdrawal.
You really do.
A person who cannot feel pleasure, cannot initiate a conversation, cannot physically motivate themselves to leave their bedroom, and cannot express emotion on their face is going to lose their entire social network incredibly quickly.
They become ghosts in their own lives.
That is so sad.
It is. And if we connect this to the bigger picture of treatment, you begin to see the true tragedy of the illness. From a pharmacological standpoint, these negative symptoms are notoriously much harder to treat than the positive symptoms.
Really. The medications don't help with the A words.
Our current antipsychotic medications do a remarkably decent job of blocking dopamine to quiet the hallucinations and dull the delusions. But they struggle immensely, and sometimes even worsen, the brain's ability to restore that lost motivation, that lost joy, and that emotional range.
Oh, wow. So you fix the voices, but you might actually deepen the apathy.
Exactly. It's a terrible trade-off.
And on top of the positive and negative symptoms, we have to look at the third pillar, the neurocognitive and disorganized symptoms. This is where the brain's switchboard seems to completely short-circuit.
Yes. Patients experience heavy, measurable deficits in executive functioning. That is, the higher-level cognitive ability to plan, to prioritize tasks, to anticipate consequences, and to make complex decisions.
And their working memory, the ability to hold and process pieces of information in the short term, like remembering a phone number long enough to dial it, is severely impaired.
And their vigilance, their ability to sustain focused attention on a task without getting derailed by internal or external stimuli, drops significantly.
This profound cognitive impairment leads directly to the disorganized speech and behavior we see on the wards. The very way they use language to communicate can become deeply, fundamentally confused.
And as clinicians, we document these disorganized speech patterns very specifically because they give us a direct window into the state of their neural networks.
Let's go through some of those patterns. There's echolalia.
Right. Echolalia is the inappropriate parrot-like repetition of another person's words. You ask, "How are you feeling today, John?" And they just respond, "Feeling today, John. Feeling today, John."
Then there's word salad.
Word salad is exactly what it sounds like. It's the brain stringing together words that have absolutely no logical semantic connection to each other whatsoever. It sounds like a broken algorithm.
Patients might also create neologisms.
Yes, these are completely made-up words that possess deep, intricate meaning only to them, but are total gibberish to anyone else.
And clang associations, which is a fascinating, if troubling, neurological quirk. It's the repetition of words that are similar in sound but not in meaning.
They are guided by the phonetic sound rather than the concept, often rhyming without reason, like saying, right, light, sight, might bite over and over in the middle of a sentence.
It's so confusing to listen to. And the disorganized behavior is just as striking and, frankly, very visually jarring for anyone witnessing it.
Very much so.
They might exhibit echopraxia, which is involuntarily perfectly imitating the physical movements of whoever is standing in front of them.
Or they might fall into catatonia, which includes severe psychomotor disturbances ranging from wild, unprompted agitation to complete stupor or mutism, where they don't move or speak for days.
One of the most fascinating and bizarre behaviors documented is waxy flexibility.
Yes, waxy flexibility.
This is a state where a patient will hold their body in an odd, highly unusual, and often incredibly physically uncomfortable posture for extended periods of time, sometimes for hours on end, seemingly without feeling muscle fatigue.
It's incredible to witness.
If a psychiatric nurse gently takes the patient's arm and moves it up into a new, elevated position, the patient will just keep it suspended there, exactly where it was placed, like a wax figure being molded by an artist.
It really drives home the profound concept of a disruption in the sense of self.
I'm glad you brought up that specific phrase. That concept of self-disturbance is profound and is the philosophical core of the schizophrenia experience.
It absolutely is.
For healthy individuals, we have an innate automatic sense of where our mind ends and the world begins. But for people with schizophrenia, that essential barrier between what is internal and what is external completely breaks down.
They cannot reliably neurobiologically distinguish their own internally generated thoughts from external reality. That breakdown is the fertile soil from which hallucinations and delusions grow.
Think about it. When your own internal critical monologue feels like it's literally being broadcast from a physical speaker across the room.
Or when a random intrusive thought feels like it was physically, surgically inserted into your brain by an outside agency.
The world becomes an incredibly hostile, invasive, and confusing place. You lose ownership of your own mind.
You really do.
So, knowing all this, knowing the sheer terror of the positive symptoms, the crushing weight of the negative symptoms, the cognitive deficits, the loss of the sense of self, how does a psychiatric nurse actually step into that fractured world?
That is the big question.
How do you build a bridge to a human being whose reality is fundamentally biochemically different from yours? This brings us to the true art of psychiatric nursing and the absolute necessity of the therapeutic relationship.
We hear it all the time in nursing school. Trust is everything.
But as we've established, these patients during an acute phase often have zero insight into their illness. The clinical term is anosognosia, right?
Yes, anosognosia. They are neurologically incapable of recognizing that they are sick. They firmly, genuinely believe the delusions are reality.
So a nurse can't just walk into the room with a clipboard and say, "Hi, you have schizophrenia, you are hallucinating, please take this pill."
No, it will instantly backfire. It requires an immense amount of deliberate patience, unwavering consistency, and a completely radically non-judgmental approach.
Establishing the therapeutic alliance is the absolute cornerstone of all subsequent psychiatric treatment.
If a patient fundamentally trusts the nurse, they are infinitely more likely to agree to take their medication, to eat their meals, and to participate in unit therapies, even if they still secretly harbor the belief that the CIA is monitoring the hospital.
And building that specific kind of trust requires mastering a very specific, highly disciplined type of therapeutic dialogue, especially when you're actively handling a patient's delusions and hallucinations.
The golden rule for clinicians, and really it's a rule that family members desperately need to learn as well, is this: you must never explicitly discount the patient's experience as fake.
Or try to stubbornly argue them out of it using logic and facts.
Exactly. Arguing facts with a delusion triggers the backfire effect. It just makes them dig their heels in deeper and destroys your credibility.
But conversely, you must never collude or agree with the delusion either.
Right. You do not pretend that you see the hallucination too, because that reinforces the psychosis.
So what's the middle ground?
The delicate tightrope technique is to validate the emotion behind the delusion without validating the fabrication itself.
Let's look at some specific, detailed clinical vignettes from the text to see how this actually plays out in a real-world scenario. Let's go back to Arnold, the 53-year-old farmer, who was court-ordered into the hospital after he lost his mother and his farm.
Okay.
Imagine a psychiatric nurse is doing routine night checks, and they find Arnold sitting up in his bed, talking animatedly to empty space in the corner of the room. The nurse knows Arnold believes his dead mother is visiting him.
Okay, setting the scene.
If the nurse takes an ineffective, purely factual approach, they might say, "Arnold, whom were you talking to? You know you're having a hallucination. Your mother died a few weeks ago.
Yeah.
We attended the funeral. You have to accept she is gone." If you say that, what happens? Arnold instantly gets defensive. His reality has been attacked. He says, "What do you know? You're lying. She's right here. She's just been away." He gets angry, his heart rate spikes, and communication completely shuts down. You've positioned yourself as the enemy of his reality.
Exactly, you've completely lost him. Now, contrast that blunt approach with the effective, therapeutically nuanced approach.
How does that look?
The nurse walks in and calmly asks, "Arnold, are you talking to someone?" Arnold says, "Yes, my mother visits me at night." The nurse purposefully does not agree that the mother is standing there, but instead pivots to the emotional core.
By asking what?
By asking, "How do you feel when she visits you?"
Uh,
Arnold softens slightly and says, "A little sad, but I like to tell her about my day. I wish I could see her more often like we used to on the farm."
and then the nurse identifies the universal human emotion underneath the psychotic symptom and reflects it back. They say, "It sounds to me like you are feeling very lonely, Arnold."
Yes. Arnold pauses, agrees, and says, "Yeah, it's really nice when you take the time to talk with me."
Do you see the masterful pivot there? The nurse entirely bypassed the unwinnable factual debate about whether the mother was biologically alive and physically in the room.
By focusing strictly on how the supposed visit made Arnold feel, the nurse uncovered the underlying, very real grief and loneliness and positioned themselves as a comforting, empathetic, safe presence. They built a brick of trust.
I want to pause on that because that completely redefines how we think about interacting with psychosis. You're searching for the emotional truth underneath the bizarre narrative.
Always look for the emotion.
There was another excellent vignette that highlighted this, dealing with a much more paranoid delusion. A patient named John is on the unit, and he and the nurse are playing a casual game of pool in the day room. Out of nowhere, John casually mentions that the CIA surgically implanted a tracking transmitter in his molar while he was sleeping,
Wow.
and that the real Osama bin Laden is currently hidden on the third floor of the hospital, and the staff are trying to confuse John with the Tower of Babel so he won't intervene and expose them.
A very complex persecutory delusion.
Again, if the nurse takes the ineffective, logical route, they try to argue logistics. John, no one put a transmitter in your tooth. We don't do dental surgery here. The CIA isn't looking for you, and Osama bin Laden is dead. I work here every day. I would definitely know if a major terrorist was hiding on the third floor.
And John immediately gets suspicious.
He accuses the nurse of being a CIA operative, drops his pool cue, and storms off.
Right, because in John's mind, if you are denying the obvious truth of the CIA plot, you must be part of the plot. The effective approach is much more strategic.
When John talks about the CIA and the transmitter in his tooth, the nurse deflects slightly from the facts, but immediately offers a blanket of security. They say, well, John, I don't know anything about a CIA transmitter, but I want you to know that the staff here will keep you entirely safe.
As John gets more agitated and elaborates on the massive, sweeping government conspiracy involving the FBI, the ATF, and the military all actively hunting him down, the nurse actively listens for the underlying emotion.
And says, John, I would think that's pretty terrifying to have all these massive government agencies out looking for you. You must be feeling scared a lot of the time.
And John stops. His shoulders drop a bit, and he admits it is terrifying. He then goes on to say he's had to handle scary, impossibly hard situations all his life, constantly feeling like a target, never quite living up to his demanding parents' expectations.
And there it is. The nurse used the paranoid delusion as a doorway to discuss John's real, deep-seated, historically valid feelings of inadequacy, vulnerability, and fear.
It's truly an incredibly difficult skill to master. It takes so much emotional regulation from the nurse not to just argue reality.
And once that foundational trust is established through those conversations, the nurse and the patient have to eventually transition to working together to set manageable wellness goals for discharge.
But because of those cognitive deficits we discussed earlier, the lack of executive function, the crushing abolition, the easily overwhelmed working memory, you absolutely cannot just hand a patient with schizophrenia a massive, complex life plan.
If you give them a 5-step plan, they will fail at step 1 and give up.
The literature highlights the choose, get, keep model for psychiatric rehabilitation. The primary directive is to avoid overwhelming the patient.
So, for example, if a patient has gained a significant amount of weight from their antipsychotic medications, setting a broad goal like I need you to lose 25 pounds this year is a guaranteed recipe for failure.
It's too abstract, it's too big, and it requires too much sustained executive function. Instead, the nurse sits down and helps them set incredibly small, hyper-specific, immediately achievable steps.
Like I will eat French fries only twice a week instead of every day.
Or, I will walk outside in the courtyard for exactly 10 minutes a day. It's about securing tiny daily victories to slowly, meticulously rebuild their shattered sense of agency and self-efficacy.
Exactly. And we have to acknowledge that those tiny, hard-won victories are often achieved while the patient is battling intense, exhausting biological headwinds.
Which brings us to the complex, often dark reality of pharmacological treatment. Managing antipsychotic medications is a high-stakes, incredibly dangerous tightrope walk.
As clinicians, we must deeply acknowledge the massive, sometimes agonizing physical and psychological burden placed squarely on the patient's shoulders when they are prescribed these drugs.
To truly understand why patients hate taking them, and to understand the severe side effects, you have to understand the underlying mechanism of action in the brain.
Antipsychotic medications primarily work by blocking dopamine transmission, specifically at the D2 receptors in the brain.
The prevailing dopamine hypothesis suggests that a severe hyperactivity of dopamine in a specific brain region called the mesolimbic pathway is what directly causes the positive symptoms, the terrifying hallucinations, and the bizarre delusions.
So the pharmacological logic is simple. Block the dopamine receptors in the mesolimbic pathway, and you stop the psychosis.
But the human brain is an incredibly dense, interconnected web. You can't just selectively drop a chemical smart bomb to block dopamine in one tiny specific area like the mesolimbic pathway without heavily affecting the rest of the brain's delicate dopamine networks.
And that's exactly where the cascading side effects come in.
Historically, in the mid-20th century, we had the first-generation antipsychotics, drugs like haloperidol or chlorpromazine. These were essentially pharmacological blunt instruments.
They blocked D2 receptors very effectively across the whole brain, which quieted the voices, but because they also blocked dopamine in the negrostriatal pathway, which regulates motor movement, the neurological, Parkinson's-like side effects were severe and highly visible.
Then in the later decades came the second generation, or atypical, antipsychotics, the newer drugs like risperidone, clozapine, olanzapine, and ziprasidone.
These drugs still block dopamine, but they also heavily target other neurotransmitter receptors, most notably serotonin.
They are generally considered more effective at treating both the positive symptoms and, to some extent, the negative symptoms. But they trade the severe motor side effects for their own set of incredibly dangerous, insidious internal physical risks.
If we connect this to the broader concept of risk versus reward in modern medicine, you see clearly why certain highly effective drugs are used strictly as a last resort.
Let's look closely at clozapine. Clozapine is widely considered the gold standard, highly effective for severely ill, treatment-resistant individuals who simply haven't responded to multiple trials of other antipsychotics.
It can literally wake a person up from a catatonic state.
But it carries a massive, terrifying black box warning for a condition called agranulocytosis.
This is a dangerous, rapid, life-threatening drop in white blood cells, specifically the granulocytes, which are the first responders of the immune system.
The absolute neutrophil count can plummet below 500 per cubic millimeter. Without these crucial immune cells, the patient's body cannot fight off even the most basic bacteria, and a simple scratch or a mild cold can rapidly escalate into a fatal systemic sepsis.
Because of this extreme risk, patients who are prescribed clozapine are subjected to a massive logistical and physical burden. They must have their blood drawn and tested weekly for the first 6 months, and then biweekly after that.
And the really scary part, which makes the nurse's job so critical, is that even with strict weekly blood draws, the white blood cell counts can drop precipitously in just a matter of 2 or 3 days.
You could have a clean blood test on Monday and be in full agranulocytosis by Thursday.
So a psychiatric nurse can't just blindly rely on the lab schedule. They have to be hypervigilant, constantly monitoring the patient for any early, subtle signs of bacterial infection.
If a patient on clozapine complains of a mild sore throat or spikes a low-grade fever, it is not just a cold. It is treated as a potential life or death emergency requiring an immediate stat blood draw.
And it's not just clozapine. Another second-generation drug, ziprasidone, carries the risk of a condition called DRESS,
which stands for drug reaction with eosinophilia and systemic symptoms.
It's a rare but incredibly life-threatening delayed hypersensitivity reaction. The patient develops a fever, a widespread rash, massively swollen lymph glands, and then it attacks the internal organs, leading to sudden liver or kidney failure.
DRESS has a roughly 10% mortality rate. So the patient is sitting there being asked by their doctor to swallow a pill every morning that successfully stops the terrifying voices of demons, but could literally statistically kill them through a catastrophic autoimmune reaction.
It's a terrible, agonizing bargain to offer a human being, and recognizing that bargain directly explains what we in the field call the adherence crisis.
The literature consistently notes that roughly 50% of patients with schizophrenia will completely stop taking their medications within a year of discharge.
When you actually sit down and look at the side effect profile, it goes from being frustrating to becoming entirely logically understandable why they quit.
Beyond those rare life-threatening risks, there are the daily, chronic, quality-of-life-destroying side effects.
Second-generation antipsychotics are notorious for altering the body's metabolism and causing massive rapid weight gain. A previously healthy patient might gain 20 to 30 pounds in a single year on olanzapine.
That rapid weight gain predictably leads directly to metabolic syndrome, severe lipid abnormalities, and the development of type 2 diabetes.
They also cause profound, heavy sedation. Patients describe feeling like they're walking through thick mud all day, completely unable to experience the sharpness of life.
And then there is the endocrine impact, specifically hyperprolactinemia. We mentioned earlier that these medications block dopamine indiscriminately across the brain.
Well, there is a specific pathway called the tuberoinfundibular pathway, where dopamine's normal job is to repress the release of prolactin, which is the hormone that regulates lactation and breast tissue growth.
When the antipsychotic drug blocks that dopamine, the brakes are taken off, and prolactin levels skyrocket in the bloodstream.
The physical result. Patients can develop gynecomastia, the rapid, painful enlargement of breast tissue, and this happens in both biological sexes.
Males develop breasts, and they might even start actively lactating.
Can you imagine the psychological horror of that?
You are already struggling daily with a shattered, disrupted sense of self. You might actively be dealing with bizarre somatic delusions about your internal organs mutating. And suddenly, because of the medicine you are forced to take, your body rapidly balloons by 30 pounds, you develop breasts, and you start lactating.
It is deeply, fundamentally distressing and humiliating. It completely alters their body image. Frankly, it's no wonder adherence is a massive challenge.
It requires immense, profound empathy from the nursing staff to coax a patient through that distress. And those nurses must remain ever vigilant on the floor, because beyond those chronic, slow-building side effects, there are serious, acute, sudden complications.
These are severe, dramatic physical reactions to the psychiatric medications that can rapidly turn a routine Tuesday on the psych ward into a life-or-death medical emergency.
The first major category of these emergencies is extrapyramidal side effects, or EPSEs.
These occur specifically because of the pharmacological blockade in the nigrostriatal pathway, which is located in the basal ganglia. Normal, smooth motor function requires a highly delicate, perfectly balanced seesaw between two neurotransmitters, dopamine and acetylcholine.
When the antipsychotic drugs come in and heavily suppress the dopamine side of the seesaw, acetylcholine suddenly becomes relatively dominant and hyperactive.
This neurochemical imbalance causes a range of devastating, highly visible motor abnormalities.
Let's walk through the specific types of EPSEs, because the clinical descriptions are intense and nurses have to recognize them instantly. First, there's pseudoparkinsonism.
The patient rapidly develops a classic resting tremor in their hands, a stiff, rigid, shuffling gait where they take tiny steps, and a mask-like, completely expressionless face.
To an outside observer, it looks exactly like advanced age-related Parkinson's disease, but it is entirely drug-induced and happening to a 22-year-old.
Then there is acute dystonia. This usually happens very early in the treatment, often within the first few days of starting a new drug or increasing a dose, and it is visually frightening.
The patient's muscles suddenly, involuntarily tense and contort dramatically, locking into painful positions. The literature specifically highlights two terrifying forms: oculogeric crisis, where the extraocular muscles that control the eyes forcefully spasm and pull the eyeballs permanently upward, locking them in place.
So the patient is physically forced to stare blindly at the ceiling, unable to look down.
Or torticollis, where the thick muscles of the neck violently seize and pull the head rigidly to the side or severely backward.
Imagine experiencing your body violently turn against you like that while you are already terrified, paranoid, and psychotic.
Thankfully, this is one area where nurses can intervene quickly. They can treat this rapidly with intramuscular injections of anticholinergic drugs like diphenhydramine or benztropine, which essentially suppress the overactive acetylcholine and level the seesaw back out, releasing the muscle spasm in minutes.
Another deeply distressing and, frankly, insidious EPSE is akathisia.
This isn't a locked muscle spasm. It is a horrific, relentless-driven inner restlessness.
The patient feels an unbearable, agonizing urge to keep moving. They're shifting from foot to foot, pacing the halls constantly, unable to sit in a chair for more than 30 seconds. They will tell you it feels like they want to jump out of their own skin.
What makes akathisia so incredibly dangerous in a clinical setting is that it is frequently, tragically misdiagnosed by less experienced clinicians or emergency room doctors as worsening psychiatric anxiety or an escalation of the patient's underlying psychosis.
If a doctor misinterprets this sheer physical, drug-induced restlessness as psychiatric agitation, their logical but flawed response might be to actually increase the dose of the antipsychotic medication to calm the patient down.
That is the exact wrong intervention.
Increasing the dopamine blockade will aggressively worsen the akathisia, driving the patient to a state of absolute suicidal desperation. It is one of the leading reasons patients abruptly and permanently quit their medications.
And if they do manage to stay strictly on the medications for years, tolerating all of that, they still face the looming long-term risk of tardive dyskinesia, or TD.
Tardive meaning late appearing. This is a devastating complication because it is often irreversible, even if you completely stop the offending drug. The brain's receptors have permanently adapted.
It involves constant, involuntary, repetitive movements, predominantly of the facial muscles and mouth. You see constant lip smacking, puckering, chewing motions.
There's a highly specific presentation called the bonbon sign, where the patient's tongue involuntarily rolls around the inside of their cheek, pushing it out as if they are sucking on a piece of hard candy.
They might also develop aethetois, which are slow, worm-like writhing movements of their fingers and toes.
It is a highly visible, deeply stigmatizing condition that instantly marks them as a psychiatric patient to the outside world, further isolating them.
And while tardive dyskinesia permanently alters the quality of a patient's life, another complication, neuroleptic malignant syndrome, or NMS, immediately and aggressively threatens the patient's life.
NMS is a critical, top-tier medical emergency. It is relatively rare, but it is lethal if missed. It usually hits within the first week of starting a highly potent antipsychotic drug or rapidly changing a dose.
The cardinal signs are a sudden, severe change in mental status, going from alert to deeply confused or stuporous.
This is paired with severe lead pipe muscle rigidity where the limbs are stiff as boards and cannot be bent.
Because the muscles are contracting so violently, they generate massive amounts of heat, leading to a dangerously high fever, often rapidly spiking between 101 and 103 degrees Fahrenheit or higher.
And finally, autonomic lability, meaning the brain's automatic control centers fail, their heart rate skyrockets, their blood pressure wildly fluctuates between hypertension and hypotension, and they sweat profusely.
If a psychiatric nurse sees that specific constellation of symptoms, the sudden confusion, the board-like rigidity, the spiking fever, they don't wait for a doctor's rounds.
The immediate, non-negotiable nursing action is to hold and stop all antipsychotic medications entirely, period.
You are now in a medical ICU situation, not just a psychiatric one. The muscle rigidity is physically breaking down muscle tissue, releasing proteins that will destroy the kidneys.
The nurse will immediately deploy cooling blankets and ice packs to forcefully bring down the fever, rigorously monitor their 5E hydration to flush the kidneys because they are sweating out all their fluids, and physically protect their rigid, locked joints from physical injury during the rapid transfer to a medical surgical unit.
There is also the distinct risk of an anticholinergic crisis.
We just mentioned earlier that anticholinergic drugs, like benztropine or diphenhydramine, are routinely given to patients to counteract those motor side effects, the EPSCs.
But if a patient gets an accidental overdose, or if they're highly sensitive, or, as is often the case, they're taking a cocktail of multiple different psychiatric and medical medications that all have mild anticholinergic properties, the cumulative effect can push them into a crisis state,
Which presents as an acute toxic delirium.
In medical and nursing training, there is a famous, slightly morbid mnemonic used to remember the exact symptoms of an anticholinergic crisis because it affects the whole body. The phrase is, hot as a hare, blind as a bat, mad as a hatter, dry as a bone.
Let's break that down. Hot as a hare because their internal temperature regulation fails. They develop a fever, and their skin becomes visibly flushed and red.
Blind as a bat because the medication causes their pupils to dilate widely and freeze, making any bright light agonizingly painful and severely blurring their vision.
Mad as a hatter because the toxicity in the brain causes an acute, agitated delirium, profound confusion, and vivid visual hallucinations that are different from their typical schizophrenic hallucinations.
And finally, dry as a bone because the drug completely blocks the body's secretory glands. Their mouth becomes completely painfully parched, they stop producing saliva, and crucially, they stop sweating entirely, which is why they overheat.
If this specific toxidrome is recognized, it's treated in the medical unit with a specific pharmacological antidote called physostigmine, which reverses the blockade.
Walking through all of these massive pharmacological emergencies really highlights a fundamental truth. Psychiatric care cannot ever occur in a localized vacuum.
You aren't just treating a disembodied brain. The brain is intricately, biologically connected to a very vulnerable physical body.
This brings us to the absolute necessity of holistic care, integrating the mind, the body, and the family system. Here is a devastating statistic that every psychiatric professional knows. People diagnosed with schizophrenia are dying, on average, up to 20 years earlier than the general population.
Let that sink in for a moment. 2 entire decades of human life lost.
And while suicide is certainly a significant factor, especially in the early acute phases, that massive early mortality rate is largely driven by preventable physical comorbidities that go entirely unmonitored by a fragmented healthcare system.
We talked about the severe medication-induced weight gain, predictably leading to metabolic syndrome, lipid disorders, and type 2 diabetes, which in turn leads to early cardiovascular disease and fatal heart attacks.
But there are other fascinating, uniquely complex physical challenges that psychiatric nurses have to manage that you wouldn't typically see on a standard medical floor. For instance, smoking.
The rates of heavy tobacco smoking are incredibly disproportionately high among patients with schizophrenia. Some studies suggest up to 80% smoke.
And here is where pharmacology and holistic care collide in a truly mind-blowing way. Smoking cigarettes actually physically speeds up the liver's metabolism of certain specific antipsychotic medications, particularly olanzapine and clozapine.
The hydrocarbon smoke actually physically induces specific enzymes in the liver, specifically the CYP450-1A2 enzyme, which then acts like chemical Pac-Man, chewing up the psychiatric drug much faster than normal.
It creates a massive logistical trap for the healthcare team. Imagine a scenario where a patient living in the community is relatively mentally stable on a high dose of an antipsychotic, but they are chain smoking a pack and a half a day.
The doctor has calibrated their high dose specifically to counteract how fast the liver is burning through it.
Then, the patient gets admitted to an inpatient hospital for a minor issue. Hospitals are strictly smoke-free zones. Or maybe the patient decides to join a cessation program and uses a nicotine patch, which doesn't contain the smoke that induces the liver enzyme.
Suddenly, without the smoke, their liver slows down to a normal metabolic rate.
But the hospital pharmacy is still giving them that massive, smoker-calibrated dose of the antipsychotic. Because they aren't metabolizing it as fast, the blood levels of the drug rapidly, exponentially spike to toxic levels.
They are suddenly hit with severe sedation, massive blood pressure drops, and severe extrapyramidal side effects, all simply because they stopped smoking.
It is a perfect, terrifying example of why psychiatric nurses must monitor literally everything going into a patient's body. Another critical, bizarre mental issue seen on the psych wards is fluid balance, specifically a condition called psychogenic polydipsia.
For complex neurobiological reasons that researchers are still actively studying, possibly linked to hypothalamic dysfunction or a side effect of dry mouth from the meds, a subset of patients with schizophrenia develop a relentless, uncontrollable compulsion to drink massive, excessive amounts of water.
They will obsessively seek out fluids, drinking from sinks, showers, or even toilets if denied access. This compulsive, continuous drinking severely dilutes the natural sodium levels in their bloodstream, leading to a state of severe hyponatremia.
This isn't just a mild imbalance, it leads to fatal water intoxication. As the blood becomes diluted, water rushes into the brain cells via osmosis, causing massive brain swelling.
It quickly causes confusion, severe seizures, coma, and brain herniation leading to death.
To prevent this, psychiatric nurses have to implement strict, locked fluid restrictions, rigorously monitor the patient's urine-specific gravity, and weigh the patient daily to catch rapid fluid retention before it reaches a lethal threshold.
It requires constant vigilance. And there's also a significant issue with basic thermoregulation, isn't there?
The underlying brain illness itself, compounded by the heavy antipsychotic medications, can severely disrupt the hypothalamus, disabling the body's natural ability to accurately sense and physiologically respond to environmental temperature.
A patient might be totally neurologically oblivious to freezing, sub-zero weather, walking outside in the snow in just a t-shirt without shivering.
Or conversely, they might put on a heavy winter parka, gloves, and a wool hat in the dead heat of a humid July afternoon.
If there isn't a nurse, a social worker, or a dedicated family member actively watching out for them, they can easily suffer from severe frostbite, hypothermia, or fatal heat stroke, simply because their brain's internal thermometer is no longer processing the external reality correctly.
Exactly. And who is usually the one watching out for them, checking their winter coats, and monitoring their water intake when they aren't safely locked in a hospital ward? The family.
We absolutely must address the immense, crushing burden placed on the family system. When a young adult is diagnosed with schizophrenia, the parents often involuntarily transition from being parents to becoming full-time, lifelong medical and psychiatric caregivers.
The initial reaction to the diagnosis is almost universally profound shock, fierce denial, and a deep, agonizing grief. They are actively mourning the death of the future they thought their child was going to have, the college graduations, the marriages, the careers.
And while processing that grief, they have to navigate a notoriously complex, fragmented, and underfunded mental health system, all while fighting the heavy, suffocating stigma of their own community.
Stigma is an incredibly powerful, destructive force. It isolates the family exactly when they need community support the most.
The clinical texts shared a specific story that really perfectly captures the insidious power of that societal stigma. It's a vignette about a highly intelligent young man, let's call him BGW.
He was a bright teenager who occasionally dabbled in recreational LSD and explored the occult, and he unfortunately suffered a severe, terrifying psychotic break at age 16. It was the scariest moment of his life and his family's.
For years afterward, BGW loudly and publicly blamed his entire episode of psychosis strictly on the teenage drug use, the satanic rituals. Why would he do that? Because to him, and perhaps to his socially conscious family, it was culturally far easier, far more palatable to adopt the identity of a recovering drug addict who made a bad choice messing with black magic than to accept the permanent biological diagnosis of schizophrenia.
He eventually got stable on a good regimen of antipsychotics, quietly got his GED, and brilliantly pushed through to go to graduate school. But he hid his illness entirely from his new life.
He kept his daily medication a dark secret from everyone in his demanding grad program until the crushing academic stress finally caused a severe, very public relapse. The societal stigma against the word schizophrenia was so heavy, so shameful to him, that he risked his own mental health and his academic career just to hide his biological reality.
Stigma forces brilliant people into the shadows. It forces them to lie. And when we talk about family involvement and psychoeducation, evidence-based nursing practice emphasizes a modern, crucial shift. We must allow the patient to dictate and define who their family actually is.
Because of the strain of the illness, biological families are sometimes estranged. A patient's true family might be a trusted peer from a local support group, a compassionate neighbor who checks on them, or a romantic partner.
Whoever fills that role, extensive, compassionate psychoeducation for that specific support system is crucial. They need to be taught how to communicate effectively without arguing facts, how to subtly monitor for medication side effects, how to recognize the early prodromal signs of relapse, and most importantly, how to maintain their own hope.
So what does this all mean? We spent the last hour talking about terrifying command hallucinations, life-threatening medication side effects that destroy white blood cells, profound cognitive deficits that erase motivation, and the heavy, lifelong burden on families. It undeniably sounds incredibly bleak.
But the core philosophy of recovery and modern evidence-based psychiatric nursing is emphatically not a story of an inevitable Krapelin-style downward spiral into dementia. It's actually fundamentally a story of hope.
Long-term clinical studies, tracking cohorts of patients for 20 to 25 years, show a surprising statistic. Between 50% to 66% of patients can and do experience significant lasting improvement or even full clinical recovery.
That is a massive, life-altering paradigm shift from the dark days of permanently locking people away in state asylums and throwing away the key.
It is a massive shift, and we have to redefine what recovery means in this context. Recovery doesn't always mean the absolute, complete absence of every single symptom. A patient might still occasionally hear a quiet voice.
Recovery means learning to live a meaningful, self-directed, deeply fulfilling life alongside the illness. It means managing it rather than being managed by it.
And what truly facilitates that level of recovery? Yes, the pharmacological interventions, the clozapine and the risperidone, are absolutely essential to quiet the neurological storm. But the human element is what truly fundamentally heals the person.
I want to share one last incredibly moving story from the literature to really drive this point home. It's written from the intimate perspective of a brother whose sibling, Robert, was hospitalized repeatedly at age 40 with severe schizophrenia.
The medical team pulled the brother aside and bluntly told him Robert would never ever live independently again. He was considered a lost cause.
Then Robert was finally prescribed one of the newer, miracle atypical antipsychotic medications. And remarkably, it worked. His disorganized thinking cleared, the heavy delusions faded away, and the treatment team was excitedly prepping him for discharge to a group home.
But a few weeks into this detailed discharge planning, Robert's dedicated social worker, someone he had known, worked with, and deeply trusted for years, was abruptly, administratively transferred to another hospital across the city.
Instantly, within days, Robert deteriorated. The tantrums returned, the hallucinations flared back up, he engaged in dangerous behavior on the ward, the discharge was immediately canceled.
His brother wrote about this, asking the doctors, what was the biological difference between Monday, when he was fine and ready to go home, and Tuesday, when he was completely psychotic? It certainly wasn't the medication. He swallowed the exact same chemical pill both days.
The crucial missing variable was the sudden, traumatic loss of a vital, trusting human relationship.
The brother wrote something in his account that is incredibly poignant and should be required reading for every medical student. He said, let's remember that the pill is the ultimate downsizing.
Medications are the basic mechanical baseline. They simply quiet the neurochemical storm so the patient can hear you. But what truly sustainably heals people, what brings them back to reality, is a sustained, believing relationship with a fellow human being who actively sees their innate worth.
As psychiatric nurses, as doctors, or as family members, it is not just what we do to people. The pills we force them to swallow, the blood tests we draw, the locked doors we manage. It is what we do with people.
We listen to their terror, we skillfully validate their underlying emotions, we hold the light of hope for them when their own brain has extinguished it, and we patiently walk with them through the absolute darkest corridors of the human experience.
That is incredibly powerful, and it perfectly encapsulates the empathetic core of psychiatric nursing. We have covered an immense amount of ground today, tracing the journey from Kraepelin's early bleak theories to the intense pharmacological monitoring of clozapine, from the quiet despair of the negative symptoms to the profound hope embedded in the modern recovery model.
But before we wrap up today's deep dive, we always like to leave you, our listener, with something provocative to ponder, a fascinating thread to pull on your own that points to the future.
Throughout the clinical text we reviewed, there was a very brief, tantalizing mention of emerging, cutting-edge research regarding the gut microbiota. We now know definitively that the natural intestinal flora, the billions of bacteria in our gut, is absolutely necessary for healthy brain development.
We know there is an active, robust gut-brain axis, a literal two-way biological communication highway where gut bacteria send chemical signals directly to the central nervous system via the vagus nerve.
This raises an incredibly important paradigm-shifting question for the future of psychiatry. The emerging hypothesis suggests that severe abnormalities or imbalances in the gut microbiota might actively increase the production of systemic inflammatory cytokines.
These inflammatory markers travel up the vagus nerve, cross the blood-brain barrier, and literally cause neuronal damage and abnormal brain development, directly contributing to the onset of severe psychiatric disorders like schizophrenia.
If that gut-brain link proves to be a massive, significant etiological factor, just imagine how radically the future of psychiatric care will change. Could the psychiatric wards of the next decade, instead of immediately reaching for heavy, dopamine-blocking antipsychotic medications with all their devastating, life-altering side effects, be heavily focused on prescribing hyper-personalized, biome-altering diets, targeted prebiotics, and advanced probiotic therapies right alongside them?
Or perhaps even before them. If the gut and the brain are that intrinsically biologically linked, could healing the bacterial biome of the gut be the ultimate foundational key to finally healing the split mind?
What a profound thought. Healing the gut to heal the mind. It completely upends how we have viewed the biology of mental illness for the last 100 years. Thank you so much for joining us on this extensive deep dive into the complex world of schizophrenia spectrum disorders. We genuinely hope this conversation has given you a much clearer, deeper understanding of the intense clinical and neurochemical realities. But far more importantly, we hope it encourages you to view mental health care and the incredibly brave people walking that difficult, often terrifying path through a lens of profound empathy, enduring patience, and integrated holistic science. Keep questioning what you know, keep learning, and above all, take care of each other.